The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, we're going to give it about one more minute just to allow other folks to roll onto the session with us. In the meantime, this welcome page lists a few emails you can contact if you have any questions about your continuing education credits or if you're having tech issues. So I encourage you to write these emails down. I will also check. So see you in about 1 minute. Okay. We are going to get started then. Hi everyone, thank you for being here for our final session of the 2021 Southwest Idaho Peer Support Connection Conference with Empower Idaho. My name is Anna Guida, I'm the program manager here at Empower Idaho, and I'm just so happy you all chose to be here with us this afternoon. We're super excited to have Kyle Davis, Dr. Kyle Davis here with us. He's done several presentations with Empower Idaho in the past, and we just really enjoy his presence and all of his great expertise he has to share. A few quick notes about kind of the control panel and how GoToWebinar works. In your control panel, which is a little teeny box like on the side of your screen that you should see, you have a few options, and one of them is this question or chat box. Dr. Davis really encourages lots of interaction with folks, so throughout the session, feel free to answer or ask questions or put your comments in there, and he and I will both be reading through those, and he kind of likes to answer them in real time. So please do that. We also have the PowerPoint uploaded as well in the handouts chat or handout section as well, so you can download and follow along. Lastly, there's an evaluation after the session. I encourage you to participate in the evaluation. It really helps us pick topics for the next sessions we do. So without any more chatting for me, I'll pass it over to Dr. Davis. And again, thank you so much for being here. And I'm looking forward to your session.
Yeah, thanks so much for having me. I'm always excited to do these presentations, and they also give me a chance to do something a little bit different than what I normally do. So it's pretty fun for me. All right, so give me a second. We'll get everything set up.
Okay, let me know if you need anything from me.
Okay, just got to click a few buttons. All right, so can everybody see my slides now? And we'll probably have to use the chat box to answer this question.
I am actually unable to see your screen.
Oh, okay.
Real quick.
Oh, I had to click another button. Okay, there we go.
There we go.
All right, and then chat box. Let me see how that's working. Can you change the chat settings, Anna? Right now, I can't chat to participants. It looks like I can only chat with organizers.
Great, you should be able to now. Go ahead and give it another try.
Okay, it looks like something changed. Perfect. All right, so if you are out there in the audience and you can hear me right now, can you type in the chat box and just say hello? And also maybe I'll take advantage of having you all use the chat real quick to answer a question for me. One of the things that this presentation is really focused on is learning more about psychopathology in general, or basically the science of mental health disorders. And I'm curious if there's anything specifically that people were hoping to learn today. So I haven't seen any responses in the chat yet. I'm wondering if they can respond to me. So Anna, I think there may be another setting for participants to be able to chat with each other or me. I can chat to them now, but I'm not seeing any responses.
They're probably just coming in slowly. I see we have one about disassociation that's come in. That you might scroll down the question. Are you looking at?
Oh, okay. Everything is coming through in questions. Yeah. Is there a way that they can use the chat feature instead of question and answers?
Yeah, the chat feature is, GoToWebinar is very strange, and the chat feature is usually only able to be like, we can talk to the attendees through it as organizers, but the question box, I call it the question/chat box because they can just put in the information through the question box. It's strange, but it is kind of just the way that it's been working for us.
Okay, it's just a lot harder to read their responses this way. Okay, well now at least I can find where you're responding. It's not going to be quite as interactive as I had hoped in terms of trying to monitor this in real time. I'm saying, will you talk on dissociation? A little bit. We'll talk about dissociation in the context of panic attacks. Okay. Okay, yeah, it doesn't look like anything else too specific. So yeah, well, anyways, we'll be talking about just a general overview of some common mental health conditions. So I do know where to see your responses now. So if you have any questions that come up, you can type them in there. And now I know to look in this other place for those. And yeah, we'll do my best to respond to things. And I will continue to ask you all questions throughout the presentation today too. So, all right, let's get going. All right, so today, well, I'll stop in just a second. I'll talk a little bit about who I am, but then we'll talk about psychopathology in general. We'll talk about the classification system that we use, or the DSM-5, and then we'll talk about differences in mood disorders, anxiety disorders, and substance use disorders. And I picked these three categories because I think they're probably the most common mental health conditions that people run into. And I see a lot of confusion about the differences between those disorders amongst people that have been diagnosed with them, as well as healthcare providers, honestly. So we want to talk a little bit more about the specifics of those things. And yeah, hopefully with the helps of helping you all help the people that you're working with in terms of just having a better understanding of what they're, what they're experiencing. All right, so like Anna was saying, my name is Kyle Davis. I'm a clinical psychologist. I'm originally from Oklahoma. I did my graduate school work down at the University of Colorado in Boulder. I went out to the University of California, San Diego's Department of Psychiatry back in 2012 and completed an internship. And that's where I kind of got more involved in health psychology in general. And then came out to Boise in 2013, where I did a postdoctoral fellowship in primary care mental health integration. Moved over to St. Luke's in 2014, and I've done several different things over there. But the things that I'm still doing, I started an insomnia clinic back in 2016. I still spend most of my time treating insomnia. And I also moved my clinic to the lifestyle medicine clinic at St. Luke's in 2019. So that's where I see my insomnia patients now. And I teach a bunch of classes related to health behavior change and health topics in general, particularly regarding sleep, and then things like physical activity and habit formation and things like that. So if anybody's interested in general learning more about that kind of stuff or that part of my work, feel free to ask about that later. And yeah, if you're interested in those classes, we could get you the information for those. All right, and then I also wanted to say a special thanks to my friend, Dr. Tina Pittman-Wagers. The reason I have her in here is I borrowed a bunch of her slides to put together for this presentation. I used to teach psychopathology labs back in graduate school, but that was a while ago now. And Dr. Pittman-Wagers is still teaching abnormal psychology and psychopathology at the University of Colorado. And so she was kind enough to share some of her slides with me. And you all can rest assured knowing that she's one of the best psychology instructors that I've ever worked with. So the material is really solid, and yeah, it was a big help to me. So anyways, special thanks to Tina. Okay, so let's talk a little bit about what psychopathology is. What do we mean by that? So very broadly, you can think about psychopathology as the study of mental illness. And when you're talking about studying mental illness, this is really all encompassing. So we're thinking about etiology, like how do people develop these kinds of conditions? How do we classify different symptoms and make them that turn into a certain set of these symptoms that become a diagnosis, and as well as treatment and prevention. So the world of psychopathology is pretty darn broad. Yeah, basically everything encompassing mental health. So yeah, compare that to something like pathology in general or physical disease. I mean, there's a lot going on. So one of the ways that can be helpful to start thinking about psychopathology is thinking about these 4 different criteria. One is deviance. So that means that what the person is experiencing or how they're behaving, how they're thinking is inconsistent with cultural norms. And that's really important because different cultures view different types of behaviors and thought patterns and experiences people have differently. So something that's deviant in one culture, and when we mean deviant, we really just mean different. Different than the normal. It doesn't mean that there's any sort of something bad about this. It's just different. And then another key component is distress. So the person's thoughts or behaviors are causing them to experience some sort of distress. They're also likely to be causing distress to those around them. And then dysfunction means that it's causing, what they're experiencing is causing them some sort of impairment in their day-to-day functioning. So when you all think of impairment, what kinds of impairment do you think would be important here? How would this show up in somebody's life? Like what would they be unable to do if they were experiencing dysfunction? We'll use the chat here again.
Hey Kyle, this is Anna. Did you see my message? You can make the questions larger. The question box larger.
Oh, okay.
Yeah.
Yeah, I can make it. Oh yeah, when you break it out. Oh yeah, I swear, I used to be a go-to pro, and then we switched to another program called Microsoft Teams, and so I have to remember all of the nuances of it. Thanks for calling that out, Anna. That's really helpful.
Totally. So small without it, it's impossible to read. So there.
Yeah, I was like, I can only see a tiny bit of what they're saying. Okay, but we're getting some great responses here. Oh, and I missed Diane. Yes, another Okie. Yeah. So, anyways, okay. So dysfunction here, not going to work. You're seeing problems with social interactions. Maybe people are avoiding going out. They're not engaging with their peers or family members like they would. Maybe you're seeing changes in hygiene, like people are not showering or washing their clothes or those kinds of things, just not taking care of themselves. Yeah, and here we see some problems with like sleeping, eating. So those are going to be more like specific symptoms of different conditions, but you're definitely on the right track. Yeah, maybe you're having a hard time completing daily chores, tasks. And then we also have like maybe you're not getting your housework done. Maybe it's impacting your work or your career. So those are all great examples of dysfunction. Basically, whatever your role is in society, you know, whether you're a student, a worker of some sort, or somebody who, or your social interaction, you're experiencing some kind of impairment in those different areas. And then we also had relationships, communications, problem solving. Yep. So those are different areas that you would certainly see problems. And then our last factor here is danger. And so when we mean danger, that would mean somebody is a danger to themselves or other people. So next question for y'all. Can you all think of any examples of behaviors in our culture or in the United States, Idaho, Treasure Valley area? You know, what's an example of a behavior in our culture that is considered normal, but maybe considered abnormal or deviant in other cultures? So this is kind of fun to think about. And this doesn't have to be something specifically related to a mental health condition, but just thinking about behaviors in general. What's something that would be pretty normal around here that could be abnormal or deviant in other places? What do you all think? Okay, yeah, women's rights. Europeans hate how falsely smiley we are in our toxic positivity. Also, yeah, gun ownership. That's something that I was thinking about. Oh, Christmas. Okay. Yeah, so not everybody would celebrate that the same way or turn it into the spectacle that we do. Firearms, family dynamics. Yeah, I had to think about one that, you know, is not so unusual in Idaho. That would certainly be very unusual other places. Saw a guy riding his bike with a gun on his hip the other day. And in Idaho, it's like, oh, yeah, we're an open carry state. People can do that. And if you saw that in other places, some other countries, that would be quite surprising to see that, and it would certainly be considered deviant. Okay, other people are bringing up different types of family dynamics, the way people interact with family members, the way they're interacting in other relationships. Yeah, the clothing people are wearing, the way people dress. Yeah, and even something as simple as direct eye contact. That may be okay in some cultures, but not be okay in other cultures. And that could be an indication, you know, that something was going on that would be different than normal. Yeah, really great examples there. Okay. So, so this, I don't know, this is kind of an interesting one. What's an example of distress you may see in someone who's having problems with a mental health condition? So when we say distress, you know, how would you know that somebody was in distress? Okay, yeah, so maybe like crying, pacing, irritability. Yeah. So those are really good examples of distress. Behavioral changes. They're not organized. They can't keep up with stuff. They're having a hard time regulating emotions. Yeah, those are really good answers. Yeah, maybe they're disengaged. Yeah, maybe they're avoiding society by sleeping all the time, or they're experiencing a lot of distress over not sleeping. I definitely see that in my insomnia clinic. Yeah, so another way you could think about this is they're probably somebody in distress is probably kind of preoccupied with something going on in their minds or their mental experience. Okay, and then I think you all did a really good job of answering this dysfunction question earlier. And then danger, you know, that probably we don't need to expand on a whole lot. We can all imagine what it would mean to be in danger of other people or to ourselves, whether that's, making risky decisions that could put other people at harm, or like directly threatening ourselves or other people. Oh, interesting. Yeah, somebody's commenting on deviance here, and somebody was working as an interpreter. And oh, yeah, and if you turn down food in some cultures, then people think you're really disrespecting them. Yeah, geez, that's a really good example there. Definitely, that's something that comes up in my work with people who are trying to lose weight. They have this belief that they would offend people, and yeah, in some cultures, they very likely to offend people if they don't engage in that. Yeah, really excellent examples. All right, so let's talk a little bit about the DSM-5. How many of you have heard of DSM-5 before? Okay, so yeah, so it looks like. And then does anyone want to expand on their general impressions of the DSM-5? Do you love it? Do you hate it? Is it somewhere in between? Some people have strong opinions about this. Okay, well, it's like from the people responding, most of the people have heard of it, not everybody though. So DSM-5 is refers to the Diagnostic and Statistical Manual of Mental Disorders. So this is a publication put out by the American Psychiatric Association, most recently updated in 2013. There's been multiple iterations of DSM-5, and as you can imagine, there have been a lot of changes in what we've considered abnormal and what constitutes a mental health disorder these are constantly changing, but certainly since the DSM has been in existence. So essentially what DSM-5 does is takes clusters of symptoms and says, if you meet this criteria, this criteria, this criteria, it's been going on for this long, and that's causing a person some problems in their life, some distress or dysfunction, and that's not better explained by something else going on, like physiologically, then we would say that this person would meet diagnostic criteria for a certain disorder. So it's kind of like checkbox kind of stuff. Like you meet these criteria, then you meet diagnostic criteria for the disorder. But if you don't meet all of it, then you don't meet the disorder. Okay, so question for you all. What do you think are the pros and cons of classifying mental health disorders in this way? Let's start with the pros. What are the pros of having some sort of system to put a name on common experiences that people are having in terms of their mental health? Okay, yeah, so somebody speaking to some of the cons. It's very Americanized, right? So that's a great example. They try to call out cultural considerations in some places, but it's pretty darn hard to do. Okay, another con, misdiagnosis. You can pigeonhole someone, you get labeled with a certain diagnosis, and then whether or not you meet criteria for that can stick around with you in medical records and things like that. I see that all the time in my work. Okay, some pros: more consistent treatment options, more objective perspective. I love that. Okay, somebody's saying, yeah, it can lead to misdiagnosis or wrong diagnoses. And then another positive, it can normalize experiencing mental health conditions. It can increase awareness. Yeah, but it can also lead to more pathologizing rather than focusing on individual strengths. These are really good responses. Okay, pros, ability to have a starting point to investigate. Yep, that's another great one. So I think everything you all are saying is pretty darn accurate. When I think about some of the pros of it, it is very helpful as a mental health provider, to standardize the way that we diagnose and treat different disorders. We know it's certainly not perfect. There are a lot of gray areas when a classification system wants them to be black and white, but it helps. And this is exactly what you're all saying. So it can point us in the direction in terms of finding a treatment approach for individuals. And it also helps us guide research. We've got to be able to define what we're studying so that we can learn more about it, so that we can develop better treatments. Yeah, this is pretty much Wendy nails this here. You have a starting point to begin and to give patients hope. Yeah, I love being able to do that, and say, hey, it looks like what you're experiencing is da da da. And we know that there are effective treatments for this kind of condition. And so, yeah, I think that that's probably what you're describing, Wendy. I love being able to do that when I'm treating patients with insomnia, and yeah, offer them hope when they start recognizing that the issues that they're experiencing are pretty consistent with other people. Yeah, it's good to stop renaming things every couple of years. So have we try to get better? Yeah, so she's talking about or multiple personality disorder and dissociative identity disorder. I'm reading this last comment by Moto. So it's funny because so many cultures, if they came to the USA, will be diagnosed with mental disorders, even if it's normal in their culture to act a certain way. Yeah, that's exactly what we're talking about here, and why it's not perfect because of some of these cultural considerations, as well as, while on one hand, it can help normalize mental health conditions. It also can attach a label to somebody, which can be stigmatizing. It also can oversimplify things that can be pretty darn complicated, especially when you're seeing somebody that has symptoms of multiple mental health conditions. It's easy to throw one label on it, but that may not fully describe what's that person's been experiencing, or why they're having the problems that they're having. And as many of you mentioned, it can lead to miss or overdiagnosis. So it's not perfect, but it's better than nothing, in my opinion. And so the way I think about DSM is you take it with a grain of salt. It's like, this is our some people's best current guess about classifying these different clusters of symptoms into different disorders to inform treatment and studying these things. So any questions about DSM-5? We don't want to spend a lot of time on that because there are more fun things to talk about than the development of the DSM-5. We want to get into the specifics of the disorders, but yeah, it sounds like people are understanding of DSM-5 and its faults. Okay, so let's talk about prevalence of mental health conditions in the United States, and then we'll start looking at some specific disorders. So in 2019, there were an estimated almost 52 million adults over the age of 18 that were diagnosed with any mental illness. And so that's approximately 20% of the US adult population. We see prevalence of mental illness a little bit higher in women than men. And young adults aged 18 to 25 had the highest prevalence of any mental illness compared to adults that were older. And we'll see in just a second, these rates are even higher with kids under 18. Prevalence of mental illness was highest among adults reporting 2 or more races, followed by white adults, and then it was lowest among Asian adults. I'm curious to hear from you all. Are these numbers surprising to you at all? That 20% of people in the United States could be diagnosed with a mental health condition. This was pre-COVID. Probably those numbers are going up, I think, now. What do y'all think? Any surprises? Is it lower than expected, higher than expected? Yeah, so nobody's surprised, and if anything, this is lower than what people are expecting. Yeah, I know this can kind of, people's take on this kind of stuff can certainly be influenced, by the work settings that you're in. Like if everyone you work with has a mental health condition, then you probably start thinking that it's higher than it is. And I see this a lot when I ask people how prevalent insomnia is. Insomnia is more prevalent amongst older folks, and so people that are older, tend to report thinking that it's higher than it is, though it's still very high. Yeah, so Moto says, I think everyone has a mental health condition to some degree. Yeah, and that's an important call out here, and that's something that we'll focus on today, is that everybody likely does have symptoms of mental health conditions at times, and that's normal. But when you get these combinations of symptoms and they're causing impairment, you've had them for more days than not for X amount of time, then that's when they become disorders. But I think that that's really important to call out, that many people experience symptoms, but maybe not to the same severity as somebody who would be diagnosed with the disorder. All right, so let's look at the adolescent data. And this is old data. This was back from 2001. So an estimated 50% of adolescents had any mental disorder. And geez, I guess if this is that old, then those people would be growing up, though I wouldn't know like when. Yeah, that those people are growing up, then maybe they were included in that other data. But anyways, at that point in time, an estimated 50% of adolescents met criteria for a mental health condition, and 20% of those were experiencing severe impairment. And we were using DSM-4 back then, but any surprises there in seeing these higher rates among adolescents? Yeah, prefrontal cortex development or lack thereof. Yeah, it can definitely lead to more distress, making decisions that lead to more distress. All right, so as everyone here is aware, there are a lot of people that are experiencing symptoms of mental health conditions, and it's pretty darn prevalent, right? So we're going to say 20 to 50% of the population here is experiencing some level of impairment because of a mental health condition. All right, so let's get into some of our specifics. So we're going to cover mood disorders, anxiety disorders, as well as post-traumatic stress disorder, and then we'll do an overview of substance use disorders. All right, so the different mood disorders we're going to talk about today include major depressive disorder, persistent depressive disorder, formerly known as dysthymia, bipolar 1 disorder, and bipolar 2 disorder, and it's their cousin, psychothymia. Okay, so unipolar mood disorders refer to, well, basically major depressive disorder and dysthymia. And so lifetime prevalence rate of unipolar depression is about almost 20%. in a given year, 7% of people are experiencing symptoms of major depression. Once again, I'm sure those numbers are higher now, as Catherine is pointing out, because of COVID. We also see higher rates of depression in women than men, and that's oftentimes starting in adolescence. So one of the really important things to think about in mood disorders is that mood disorders are defined by people experiencing different combinations of mood episodes. So we're going to talk about major depressive episode, manic episodes, and hypomanic episodes, and as well as dysthymia or like mild depression, and how the different combinations of those mood episodes result in meeting diagnostic criteria for the different mood disorders. Does that generally make sense to y'all? So we'll cover some of the episodes and then how they fit together here. Okay, so major depressive episode. So this is, whenever we're thinking about meeting criteria for a depressive episode, anytime we're looking at these different criteria, it's important to remember that you probably will recognize some of these symptoms in yourself or other people you know. And just because you have some of these symptoms from time to time does not mean you meet diagnostic criteria for the disorder. Though you may certainly meet it, or maybe you have in the past, but you don't currently. But I do think whenever you present this kind of material, people have a tendency to over-pathologize themselves and like, oh my gosh, I have that, I have that, I have that, and you're like, well, yeah, that's a human experience to have these different symptoms. But when you've had them for this long and at the severity, that's when it starts to become more of a problem. So anyways, yeah, let's look at some of the specifics here. Yeah, and you're playing on WebMD or Dr. Google, you can end up with all sorts of diagnoses really quickly, especially if you're feeling anxious, right? You start worrying about it and you're looking for answers, which, that would go hand in hand with many of the conditions we talk about today. So anyways, one of the first big criteria here is that you have to be experiencing these symptoms more than half the day, nearly every day, for at least 2 weeks to meet criteria for a major depressive episode. And that's really important because you'll notice like, oh yeah, I have those a couple days of the week or something, but maybe not every day, more than half the day for 2 weeks. So to meet criteria for a major depressive episode, at least one of the symptoms somebody is experiencing is depressed mood or anhedonia, which means losing interest or in pleasure in previously pleasurable activities. Like maybe somebody used to love gardening and they no longer feel like they're getting any enjoyment or pleasure out of working in their garden. Depressed mood, that's something we're probably all familiar with, feeling down, blue, not feeling very good. It's really very much a feeling. Okay, and then, so you've got to have depressed mood or anhedonia. Depressed mood is probably more obvious a lot of the time. Anhedonia is a little sneakier because people just aren't as familiar with that particular symptom. And then some of the psychological symptoms include feelings of worthlessness and excessive or inappropriate guilt, experiencing poor concentration, difficulty thinking, difficulty making decisions, having thoughts about suicide, or it's relatedly, just thinking that maybe it would be better if you weren't here anymore, but they start contemplating or thinking like, I think I could be better off if I just wasn't here. And then maybe they start thinking about what they would be doing or what they could do to not be here anymore. And then I'm sure you all are very well aware that that's a little bit more severe. And then we have physical symptoms of depression. So seeing changes in appetite. So I think this is one of the interesting things about depression, and especially in some of these physical symptoms, you'll see them kind of clustered together in different ways. So some people will be really hungry. They have like an insatiable appetite, or they start gaining weight because they're eating a lot. Other people like lose their appetite altogether. And well, it goes hand in hand with changes in appetite, but some people are going to lose weight whenever they're depressed, and some people are more apt to gain weight whenever they're depressed. And then people are oftentimes having problems with sleep. So either difficulty falling asleep or feeling or sleeping more than is normal for them. If you were to guess which of those clusters of symptoms go together, being hungrier or losing your appetite and not being able to sleep and sleeping too much, which of those like hunger and sleep symptoms do you think go together more often? Okay, so yeah, it's kind of a confusing question, I guess. Here we go, Diane. Yep. So I think Diane got, or the way I was thinking about it. So more often than not, if somebody's having trouble sleeping, they're probably also, they would be more likely to have more problems with their appetite. People that are sleeping more may have more of an appetite or be eating more, or so you'd see sleeping more, gaining weight, not sleeping, losing weight, kind of cluster together sometimes. Okay, another symptom that you would see, this would probably go hand in hand with this as well. So psychomotor agitation or retardation. So psychomotor agitation was like fidgetiness, like somebody just can't sit still. They're like constantly moving around. And then psychomotor retardation would be like somebody is sitting abnormally still. They're just not moving very much at all. Once again, you can imagine how that kind of restlessness, irritability that people are experiencing physically would probably be related to them not sleeping, maybe not eating. Whereas if you're just, everything is more subdued or sedated, you're more slowed down, maybe eating more, and then sleeping more. Not that that really matters to anything, but I think it's kind of an interesting nuance in that you see these like distinct, like kind of presentations of clusters of symptoms sometimes. And then finally here, we've got fatigue or low energy. So oftentimes people feel really tired. Once again, that's an interesting one to me because I see it pop up in my insomnia clinic. Maybe somebody comes to me because they say, well, I'm feeling tired during the daytime. I think I'm not sleeping well because of that. Or maybe they're sleeping poorly and they're feeling tired during the daytime. And oftentimes we're able to get them sleeping better, sleeping more than they were before, and they still feel tired. And and they'll say, what, I thought I fixed this, why don't I feel better now that I'm sleeping more? And the truth is sometimes that they may be experiencing another mental health condition or the side effect of something physiological, whether a medical condition or a medication that they're taking that's causing them to feel more tired. All right, so are we all clear on major depressive episodes? I'm also wondering, anything else that you're curious about in terms of experiencing a major depressive episode? Any symptoms that you think should be included here that you're not seeing? Or anything that you see here that you don't think should be a symptom for a major depressive episode? So again, I think it's important to point out here that these clusters of symptoms, like that the way we classify things is not infallible. They were just put together by humans, just like yourself, so their best guesses about things, obviously informed by science, but they're still just our current best guesses. So it's interesting to ask other people's thoughts about that sometimes. yeah, people are saying it's like, yeah, that makes sense, but yeah, there's a lot of overlap with other mental health conditions, no doubt. Um, there's really something to be said for some of the experience of depression and anxiety and how they are more similar than maybe we people have traditionally thought about, because there's a lot of similarity in the kinds of thought patterns people have whenever they're experiencing depression and anxiety. Hmm. Yeah, maybe you're experiencing something like, what Kristen's saying, so people are surprised that when they're very down, that they had an inability to cry. And it was just like a lack of ability to express emotion. That's a really interesting call out. And I think that that is something that you would see quite a bit. People just get more flat, sometimes flat affect whenever they're experiencing mental health conditions. So you definitely may see that in depression. And maybe the stereotype is that somebody who is depressed would be like tearful all the time, but that may not be true at all. And she's also just talking about feeling stuck and feeling frustrated. Yeah, those would be pretty. Yeah, this is gets into a little bit here, psychological symptoms. Um, but you would also, we don't call this out in the diagnostic criteria, but themes of different thought patterns that people would experience. Oftentimes, people are having negative thoughts about themselves, the world, their future, and that can certainly lead to feeling more stuck and frustrated. It would be hard to see past that or imagine that anything could be different when you're feeling that down. All right. Any other comments about experiencing a major depressive episode? So we've got or five, actually, I didn't even say this. Five of these nine symptoms, and one of them has to be depressed mood or anhedonia. The symptoms have to occur more days than not, or more than half the day, nearly every day for 2 weeks. And then, if you meet all that, and what you're experiencing is not better explained by a physiological health condition or a substance, then you can meet diagnostic criteria for a major depressive episode. I one other bonus question for you all. Can you all think of any physical health conditions that could cause somebody to have a lot of the same symptoms that they would be experiencing if they were having a major depressive episode? And I guess while you're thinking about that, physical or physiological conditions, can you think of any medications that could result in some of these same symptoms? Oh yeah, really good. You guys are quick. Yeah, hypothyroidism is one of the ones that I think about first too. So either, yeah, for depression, hypothyroidism for sure. So feeling tired, down all the time, and if you're feeling really tired all the time and you don't have much energy, well, then it's very easy to start experiencing some of these other symptoms as well. Your metabolism slowing down, you're gaining weight, maybe you're experiencing like psychomotor retardation. Other people talking about autoimmune conditions like lupus, um, multiple sclerosis, migraines, hormonal disorders, chronic pain, problems with glucose. Um, yeah, now people are pointing out different medications, some SSRIs, muscle relaxers, fibromyalgia. Um, yeah, exactly, Catherine. Not everyone is the same. So, what about pain medications? Does cardiac medication cause depression? I think you could see some symptoms, from different cardiac medications. I'm no expert in that. Um, One of the things that I think about a lot, though, are that some of the medications that we use to treat these conditions actually cause some of the same symptoms that maybe we were trying to avoid in the first place. Um, so we definitely see that with different sleeping medications. I won't get into the specifics of how different different medications that people use for mood disorders can cause that, but it's definitely beneficial to kind of think about all the different factors that could be leading someone to feel this way. Any kind of gut, or yeah, I said hormonal disorders. One of the ones that you'll see in men sometimes, would be like low testosterone. And then that can cause a lot of symptoms of depression. I know one of my old supervisors used to teach or had a lecture called "Is it depression or is it disease?" And that was really eye-opening to me, because you see these overlaps in different types of even like different vitamin deficiencies, people that are low in vitamin D, vitamin B, low in iron. You'll see some of these same kinds of symptoms. And if you go to your primary care provider and they don't do those kinds of things and you present those symptoms, a lot of the times they would just put you on an antidepressant, and then that may not end up fixing the problem. And so there could be something else going on. It's not always what it looks like at face value. Yeah, and diabetes, there's definitely a lot of overlap between diabetes and depression for, I think, multiple reasons. All right, so now let's move on to manic episodes. What do we mean by a manic episode? So a manic episode can be characterized by a distinct period of elevated, expansive, or irritable mood for 1 week or more, and that causes that person to get in some sort of trouble. Usually they'll end up hospitalized or unfortunately in jail because they have gotten themselves into some sort of trouble. And oftentimes, not really cognizant of what's going on during that time. So it's a distinct period lasting for a week or more, usually results in people running into some sort of serious problem. And they have three of the following. So people will be experiencing inflated self-esteem or grandiosity. They are on top of the world. They can do anything. Decreased need for sleep. Once again, I keep talking about my insomnia clinic because that's the lens that I get to see patients in. The decreased need for sleep. I get a lot of referrals for people with bipolar disorder, and it is so important that we manage their bipolar disorder in order to help them sleep better. So, if somebody like they're only sleeping 2, 3, 4 hours a night and they don't miss it, they're like, yeah, I don't need to sleep. I can get all this stuff done. Who cares about sleep? So that's a big difference. They don't miss it, and they just keep going. People are oftentimes more talkative than usual. They may be experiencing flight of ideas or racing thoughts. Oftentimes that goes hand in hand with being more talkative than usual. They can be easily distractible. Thoughts are coming so fast that it's easy to get distracted. They'll lose track of what they were thinking about. You may see an increase in goal-directed activity or agitation. What I tend to see, are people taking on a lot of different projects at once. So, people are like, yeah, I could clean out the garage and I could work on this painting project that I want. And I really wanted to rearrange my furniture. And while I'm at it, I might as well paint the walls. So you'll see like that kind of stuff, just people taking on a lot of stuff that would be deviant, more than would be expected in that culture or for that individual. You may see excessive involvement in risky behaviors. And risky behaviors, the kinds of things you're seeing. Actually, I'll ask you because that's kind of fun. What kind of risky behaviors do you think you may see in somebody that was experiencing a manic episode? Yeah, Diane, I hear what you're saying about the extra weight stuff. People see somebody who's overweight and they say, "Oh, well, all of your problems are because of this," or that's how they're thinking about it, and it, may not be true at all, and maybe they are totally missing what's going on with somebody. Okay, so the things that y'all are calling out here, promiscuity, sexual indiscretion, grandiose spending, spending money that maybe you don't have or that should not be used for those purposes. Yeah, promiscuity, overspending, hypersexual, impulsive, reckless driving. Yeah, overspending, drug or alcohol abuse, increased sex drive. Yeah, people are just not thinking past the present moment. So back to one of the comments about prefrontal cortex development earlier, you'll see people making decisions that are just really consistent with what makes them feel good right now. Yeah, and the spending money, like I remember I was supervising someone who was meeting with the patient. They're like, yeah, they just went out and bought, I think this person had bought like 2 new cars, like a Jeep and a Corvette, or not like a Camaro or something. I was like, whoa, did you screen them for bipolar disorder? They very are likely experiencing a manic episode right now. And what can we do to help them before they get themselves in big trouble? Spending money that they probably wish, and later on in retrospect would wish they hadn't spent that way. So yeah, other kinds of things you'll see, like business investments, like people thinking that they can just do anything, or like they'll be able to manage everything. So starting new businesses, maybe they are like, and then they're impulsive and they're like firing people. Yeah, so Kate says picking fights with others. That's what I was just thinking of. Dangerous physical activities without proper safety gear training, like, hey, I'm going to climb this building, watch me. Or I'm going to, yeah, we can only imagine the different things people do. Shoplifting, yeah, that's a good example, Adele. So people may be, committing crimes just because they're not afraid of getting caught. They don't think it's possible that they could get caught. Maybe something extreme like skydiving. But yeah, indiscretion. They are getting themselves into trouble because they, really just don't have the capacity to think about long-term implications of those things, because of this like overwhelming sense that everything is gonna be fine, and really believe that in the moment. And it just results in these patterns of behavior that can be incredibly disruptive to people later on when they come back down. Okay, and so all this is also resulting in impaired functioning. All right, so I think we did a good job covering manic episodes. Once again, anything else there that you're surprised you didn't see? Darla says, doesn't PTSD look similar? Some of it. Some of the symptoms would be similar, but some of them are quite a bit different too. Probably one of the main things that you'll see different is this like inflated self-esteem or grandiosity, just feeling like everything's going to be okay, or everything's going to be really good, where PTSD would be more likely like nothing's going to look good. More bad things are going to happen. But another important call out about the manic episodes, there's some nuances here. It's not all inflated self-esteem, feeling good about things. People can also experience what we call a mixed episode, where they have a lot of symptoms of depression and they've got the increased energy and lack of sleep that can go hand in hand with a manic episode. And that can be really, really distressful for those individuals, as well as the people in their lives. Yeah, that's an interesting way to think about it, Danny. Okay, hypomanic episode. So how is a hypo, and Darla, I definitely want to respond to your question, but when we cover PTSD a little bit later on, then we can talk about differences between those two. Okay, now let's talk about hypomanic episodes. So hypomanic episode is similar to a manic episode, but less intense. So in a hypomanic episode, people are experiencing 4 or more days of feeling euphoric, expansive, of irritable, or irritable. Remember, in the manic episode, we had a criteria of 7 days. They're experiencing 3 or more symptoms of mania, and if they're in this diagnosis, if their mood is irritable, they have to have 1 more symptom than they would if their mood was euphoric or expansive. So this gets to some of those nuances of DSM and how you can tell it's like, oh, yeah, these systems are not perfect. These are just our best guesses. You got to have another symptom if your mood looks like this. You don't have to have this extra symptom if your mood is like this. So another thing about hypomanic episode, the symptoms are going to be persistent. So they're going to be consistent through that whole time period. And these are the same symptoms that we were just looking at before. Also important to remember, that this would need to be a change in functioning from baseline. One interesting thing is you'll see some similarities between hypomanic episodes, manic episodes, and people that we would say had more of like a hyperthymic personality. So oftentimes these people are like real go-getters. They're starting companies. They're like starting like lots of friendships, relationships. They're really outgoing. They don't need to sleep very much. They can accomplish a lot of work. They're really motivated. And so you'll see some of that too, but those people are like that all the time for the most part. Where hypomanic, you would see distinct differences between normal functioning or how they are when their mood is euthymic versus when it's in these other mood states. So this would be observable by other people. And importantly, in a hypomanic episode, people are not experiencing psychosis. So they're not seeing things or hearing things that aren't there. They're not causing danger to themselves or others, and they don't experience this impairment or marked impairment in functioning. So do you think people like experiencing hypomanic episodes, or would they not like experiencing hypomanic episodes most of the time? Yeah, cases. Love. Yeah, you can get a lot of stuff done, and it feels good. And so oftentimes people have pretty positive experiences with hypomanic episodes if their mood's not irritable. And it poses a really interesting issue when it comes to treatment, because the medications that are used for treatment oftentimes prevent people from having hypomanic episodes, and they're giving that up at the expense of hopefully not having as severe depressive episodes. So it's a big trade-off for people, and it's a tough decision for them to make. Yeah, and they kind of lose track of what euthymic mood is. I really like that comment. Yeah, and some people are saying like, well, that sounds nice, but yeah, in the real world, the folks that I work with, that are experiencing hypomania, mania, they're not enjoying it. Probably, it depends on your circumstances too, right? And that would have an influence on it. Yeah, Moto, maybe you've had those kinds of episodes before. Yeah, maybe you're grateful for the energy, but it can lead to problems, and that's once again so important here, is when you've got those fluctuations, it's one of the blessing and a curse, right? It's like you can do more, you feel better at certain times, and there's almost always a downside to that, or a corresponding depressive episode. And we'll talk about how these things go together in just a second. So just one more quick side-by-side comparison between mania and hypomania. So in a manic episode, 3 or more manic episode or symptoms, more than 4 or equal to 4 if it's irritable. Same thing in hypomania. So we see the same thing there. Mania, you have to experience this for at least a week of feeling euphoric, expansive, or irritable. Hypomania, that's only going to be 4 days. In mania, we see an abnormally and persistently elevated, expansive, or irritable mood. And then in hypomania, it's more of this distinct period of persistently elevated mood. So it doesn't go on as long. It's more just kind of captured in this distinct time frame. And then in mania, this is really important. This gets to the severity criteria. So hospitalization is needed to protect that individual or others. In hypomania, that does not require hospitalization. In mania, people may be experiencing psychotic features. So once again, that means seeing or hearing things that are not there, or believing something is happening that is objectively not happening. In hypomania, we do not have psychotic features. And then in mania, people are experiencing impairment in occupational functioning, their work, their social activities, their relationships with others. Once again, maybe they're starting fights, causing problems, those kinds of things, yelling at people, starting fights. And then hypomania, it's not severe enough to cause marked impairment. And then we say an unequivocal change in functioning, uncharacteristic of the person when not symptomatic. And another call out with hypomania is it's going to be distinctly different. Other people are going to notice that this is different in this individual than it would be at other times. Diane, can people see other people's comments in the question box here? I really like what Diane's writing here about what ended up leading to a differential diagnosis for them.
Hey, Kyle, Susanna, I don't think people can see other people's questions.
Okay, great. Yeah, thanks for telling me that so I can read it for everyone. So Diane was saying, for me, what led to having the bipolar 2 diagnosis removed was recognizing that the drive that they were experiencing, like an energy, was characterized because I've got these bad thoughts about myself and I feel like I have to do this stuff in order to keep going. And it wasn't like I just feel good and I want to do more. It's like I have to do this even though I'm like running myself into the ground. So that's a good comparison. And how this stuff gets kind of tricky when you've got different symptoms that could be in different like clusters of symptoms. In this particular case, we were talking about PTSD, attention deficit disorder, and major depressive disorder. You see a lot of similarities in those symptoms, and it can be confusing, to get a correct diagnosis. And one of the challenging things here is it makes a big difference what kind of medications you're on to find the best fit for someone, so that we don't end up treating the wrong thing indefinitely and causing them more side effects or other problems when we're not even addressing the primary issue. So it's tricky stuff, right? Now, I love talking about or using these graphics that we're going to look at next to talk about mood disorders because to me, it's how I think about it. It helps me understand it a lot. So what we're looking at right now is a graph of mood. The way to understand this, on the high side, or where the top of where the arrow is black, would be like a manic episode, and then on the gold arrow, that would be a depressive episode. So we've got this big range here between manic episode, depressive episode. And so what we see here in the middle is normal mood fluctuations. People's mood changes, right? Does everybody feel the same way every single day? No way. There's definitely some really normal fluctuations in people's mood that are going to happen. So how would you know how high does your line have to go, or how low does it have to go before that becomes abnormal, right? So once again, this is some of the limitations of our classification system, where it gets like pretty hard to know what qualifies as a disorder and what doesn't. And I think another thing that you see in mood disorders a lot, people don't always fit into these nice little boxes that we have, and they'll have most of the symptoms but not enough symptoms to get the diagnosis. They're definitely having problems in their life, but they don't meet all the criteria. And so these people are oftentimes lying somewhere in between, like what we would call bipolar 2 disorder and depression, even though their mood is going up a little bit higher sometimes. So main point here is it's tricky, but I think this visualization can help people understand what's going on. Okay, yeah, so Kristen has a good question. What she says, what's the difference between irritability and anxiety? So we would characterize anxiety by thinking about things a lot or worrying about things, and oftentimes things that are not necessarily really important, but just worry about things a lot. Irritability means like you're like ready to start fights. Like everything somebody says gets under your skin. Like you're more critical of other people. I know I feel more irritable, like if I don't exercise enough. And so like it's basically like at least for me, when I'm more irritable, like more critical of things, where anxiety means I'm like worried about other things going on. Okay, so let's talk about, well, so if this is what normal mood looks like, what does major depressive disorder look like? So major depressive disorder, so if a major depressive episode, so what we were just talking about, that cluster of symptoms, 5 of 9 symptoms, more than 2 weeks, causing impairment, if that occurs by itself and there's not a history of a manic episode or a hypomanic episode, then that person would meet criteria for major depressive disorder. And then there are some other things that go along with that. So there can be additional features of major depressive disorder. Sometimes people could experience catatonic features, where they're like almost like paralyzed, just like out of it, can't really interact with them. Psychotic features, once again, where they're seeing things, hearing things that aren't there. For major depressive disorder, they would only experience those symptoms in the context of a major depressive episode. Another classification is with peripartum onset. So this is occurring around childbirth. So it could be antenatal depression or postnatal depression or postpartum depression. And then another classification is whether or not somebody would have a major depressive disorder with anxious distress or not. So oftentimes when people are having major depressive disorder, they are very anxious and they are experiencing a lot of distress because of that anxiety. I was curious about this. So before the class, I was looking this up. It was like almost 3/4 of people that meet diagnostic criteria for major depressive disorder also are experiencing anxious distress. So it's real common to have that too. Yeah, Tracy says anxiety makes me irritable. Yeah, it wears you out. You can only do that. It takes a lot of cognitive energy to be worrying about things all the time. And Diane has another great comment here. Regardless of where you fall on the spectrums for these different disorders, good therapy can help anyone seeking help, right? So we don't say, oh, you only met 3 of the 4 criteria. Sorry, I don't think the treatment would be helpful for you. That's not true. The same treatment approach that would work for somebody with 4 symptoms is very likely to also work for somebody with 3 symptoms. I'm sure that makes sense to you all intuitively. Okay, so what does a major depressive disorder look like on our graph here? So somebody with major depressive disorder, their mood is coming up into this what I call it, or euthymic is just a word for normal mood, so kind of around the middle of our graph here. So their mood will go down to experiencing a major depressive episode at times, and it'll fluctuate between euthymic mood and major depressive episode. Okay, does that make sense to people? So, even if you have major depressive disorder, hopefully there are times in your life when your mood is euthymic. Okay, so next up, persistent depressive disorder, also known as dysthymia. So this is like a lower level depression that lasts for a long time. So symptoms present for 2 years in adults. It has to last at least 1 year in children and adolescents. So people with persistent depressive disorder would be experiencing depressed mood, poor appetite or overeating, insomnia or hypersomnia, same symptoms we saw before, low energy or fatigue, low self-esteem, difficulty concentrating or making decisions. Maybe they're feeling hopeless, but they don't have all of the other symptoms. Which ones? What's missing here? Can anyone call this right off the bat, like what they see different in the dysthymia criteria versus the major depressive episode criteria? There's one that stands out to me that is indicative of severity. I'm not seeing anybody saying anything yet. I don't want you to feel like you have to go look up those slides. So suicidality. So we don't see thoughts of suicide here. We also don't see anhedonia here. Okay, so what does this look like on our graph? So this, somebody with dysthymia, persistent depressive disorders, mood is going to fluctuate between euthymic mood and then a mild depression. And then that's going to occur for at least 2 years. Sometimes people will meet what we call criteria for like double depression, where they fluctuate between like mild depression and major depressive episodes, back and forth, and they don't have too many periods where they're coming up to more of a euthymic kind of mood, but mainly characterized by not quite as severe as major depressive disorder, and occurs for a longer period of time. Say you can also, if you have more severe symptoms of depression, then you could meet criteria for major depressive disorder and your episode has lasted a couple years. That would definitely be possible as well. All right, so before we move on to bipolar disorder and kind of conceptualizing this stuff, any questions about depression? All right, well, we'll also save time for questions at the end or at the end of class. So let's move on to bipolar disorder. So bipolar disorder includes both manic and depressive episodes. A common pattern for people to experience would be maybe the first time that they have an abnormal mood episode is they have a manic episode. That follows by a period of euthymic mood. Then they would have a depressed episode, back to normal, and those go back and forth between having manic episodes and depressed episodes. Sometimes people tend to stay more down, and every once in a while they come up. Sometimes they're more up than down, but the main idea here is they're fluctuating back and forth between the two. So once again, we've got two different types of bipolar disorder. We've got bipolar 1 disorder, we've got bipolar 2 disorder. There's also sometimes what we call bipolar 3 disorder or cyclothymia, but we'll talk about what this means in just a second. There's also a few different ways to think about this, or different experiences that people will have with bipolar disorder. In rapid cycling type, there are swings between depressive and manic or mixed episodes over a long period with little or no normal functioning in between. So a lot of times people are going to have long periods of time where they're at euthymic mood. Rapid cycling is like you're up and you're down, or up and you're down. And this is probably like where some of that diagnostic confusion comes into play. You know, like if you have PTSD Diane was talking about PTSD, depression, ADHD, like you're gonna see a lot of those similarity in symptoms, and they can move back and forth between themselves quickly. And it gets confusing in terms of making accurate diagnoses. But anyways, moving between these episodes really quickly. Also what I see in my, I have a 1-year-old and a 4-year-old, and this is kind of what is going on in my house around bedtime. We see a lot of rapid cycling between their moods. Okay, burden of bipolar disorder. So almost 6 million American adults have been diagnosed with bipolar disorder. About 3% of the US population age 18 or older are going to meet criteria in a given year. Also, it's important to know, or especially for me, I think about timing of things when this happens in people's lives. Median age of onset is about 25 years for people with bipolar disorder. Oftentimes you're seeing symptoms of this earlier on in life, that they haven't had a full-blown manic episode yet. Pretty darn rare to have the first manic episode later on in life. Most of the time you're going to be seeing this earlier on. You know, it's not like it comes out of nowhere in your 50s or 60s. That would be, once again, pretty rare that you would see that happen. Some other things about bipolar disorder, unpleasant facts. Suicide attempts are more likely to be lethal. Rate of completion, if you have bipolar disorder, is 5-to-1 versus 20-to-1. So you're 4 times more likely to complete suicide if you have bipolar disorder versus someone in the general population. You see equal rates in men and women. And risk factor for bipolar disorder would be a family history of mood disorders. Oftentimes you're seeing first-degree relatives that have been diagnosed with a mood disorder as well. Yeah, there you see 80 to 90% of people with bipolar disorder have a relative with depression or bipolar. And sometimes you see a lot of people in people's families that have been diagnosed with the mood disorder. Catherine, we may have to save those questions for the end of the presentation. She wants to know about my thoughts about ketamine and marijuana in treating mental health conditions. I do have thoughts about them, and I'll share them, but not in the middle of the rest of this. Okay, so bipolar 1 and bipolar 2, how are these different? So in bipolar 1, that means that you experience major depressive episodes and manic episodes. However, as we were talking about mixed episodes before, that manic episode could be mixed. And so you've got the energy, irritability, and like low mood of depression, but it's like this anxious, high energy, feeling terrible kind of situation. I wouldn't wish it on anybody. And then bipolar 2, major depressive episode and hypomanic episode. So you're going back and forth between the major depressive episode and coming halfway up that scale to hypomania. Let's take a look at, and then cyclothymia, where you're alternating between hypomania and mild depression or dysthymia. So let's look at how this looks like. So bipolar disorder, you are alternating between the top of the scale and the low part of the scale. The one thing that this graph doesn't really do justice is it doesn't represent the period of time that people would spend in euthymic moods. That's probably a little inaccurate. The next one we have for bipolar 2 is actually more accurate. So bipolar 2, my mood is going up to hypomania, going back down to normal, and then we'll drop down to depression at different times, and I'll fluctuate between the two while spending some time, with more of a normal or euthymic mood. And then cyclothymia, so alternating between halfway up and halfway down. So you've got a little more variability in your mood fluctuations than somebody who doesn't have a mood disorder, but less fluctuation than somebody that would have a bipolar spectrum disorder. So one question for you all before we jump into our anxiety disorders. Can you be diagnosed with bipolar disorder, bipolar 1 disorder, or bipolar 2 disorder, and major depressive disorder? Yes or no? What do people think? Can you have major depressive disorder and a bipolar spectrum disorder? I only see, I've got a couple quick responses here. That's what I wanted to see. Okay, so Jessica and Catherine are saying no. One of these diagnoses would trump the other because it's included in it. It's one of the pet peeves of mine whenever I see people getting diagnosed with major depression and bipolar disorder, simply because what they're experiencing can be better explained by bipolar disorder than having both of those diagnoses. And it makes it more confusing for the individual and people trying to help them when we've got these multiple diagnoses in the picture. Honestly, it's not uncommon, for somebody to come into my clinic that's been involved in mental health care for quite some time, and they'll say, yeah, I've been diagnosed with bipolar disorder, manic depressive disorder, major depressive disorder, schizophrenia, and PTSD. And obviously this person, is experiencing a lot of difficulty with their mental health. And it would be much more helpful for them to have a better understanding of their diagnoses so that they can get more accurate treatment. 3 of the things that I said would be better better defined by bipolar disorder. So, if you've ever heard somebody say, I have manic depressive disorder, that's just what we used to call bipolar disorder. Just like we changed multiple personality disorder to dissociative identity disorder. It's the same thing. So you can't be diagnosed with both of them because it's the same thing. Yep, Diane. So bipolar would encompass the major depressive disorder. So that's a better explanation of what's going on. And then you're asking about schizoaffective disorder. There's some nuances with schizoaffective disorder in terms of when people would be experiencing psychotic symptoms and their mood episodes. So that's even a more rare condition. But in schizoaffective disorder, people would have those distinct mood episodes, and they would also have the symptoms of schizophrenia at other times. So schizoaffective disorder becomes the most accurate diagnosis in those situations. It's real tricky, right? Because in schizophrenia, you can have psychotic experiences at any time. And then we also said that you can have psychotic experiences in depression and in manic episodes. So it gets really tricky. But there are ways of differentiating these things. Sometimes it makes a difference, sometimes it doesn't in terms of different treatment approaches. But sometimes it can make a really big difference. Okay, so moving on to anxiety disorders. I'm going to move through this material a little bit faster than I was the mood disorders. Okay, so specific phobias. So these are just the all the I guess it's all the anxiety disorders, but specific phobia. So phobia can be defined as excessive, unreasonable fear of something that interferes with functioning. This is really important in terms of diagnosing a phobia. So how many of you? I'm curious. How many of you would say that you have a phobia of something you can't stand? Whether it's like spiders or balloons or cereal or birds. You can tell I watch all these old Maury Povich episodes back in the day whenever they would bring people on and terrify them. So question here. If you have a phobia of snakes, so this is something Catherine said, if that's you, does that interfere with your functioning? Does that keep you from doing anything that you want to be doing? So as I'm sure you all can imagine, this functioning piece is really important. There may be things that you absolutely despise being around, but if it's not causing you impairment in your functioning, then you wouldn't meet diagnostic criteria for this. But if Catherine all of a sudden got a job at the zoo and working with the reptiles, she may have a serious problem. Or she lives in the jungle. Oh yeah, maybe it keeps you from walking in dense vegetation. Your phobia of clowns is probably not causing you too much impairment unless you are unless you're working in the sewers, Diane. Then that could cause a problem. Okay, so other notes about phobias. So the phobic object or situation is actively avoided, or if you are forced to do it, you're experiencing intense fear or anxiety. Fear, anxiety, avoidance is persistent. So this is not like a one-time thing. This has been going on for 6 months or more. The types of specific phobia categories include blood, getting some kind of injury, getting an injection. That type is really interesting because you have a different physiological response than you have in these other kinds of phobias, but that's probably beyond the scope of our presentation today. Maybe you have a phobia of specific animals, different natural, so like snakes, different natural environments, like being in sewers, to Diane's point. Other things would be like getting specific illnesses or like hypochondriasis, thinking you're sick all the time. So that's once again its own thing. And like maybe a fear of choking. Lifetime prevalence is about 12%, more common in women than men. But a lot of these times, so I think people these are like what we'll call irrational, maybe you may say rational, fears of these different kinds of situations is pretty normal. But for most people, it's not going to cause significant impairment in their life. But if you've got a phobia of like flying or something, then that can start affecting people more commonly because you're not able to do some of the things that maybe you would like to be able to do. Or heights, I can't go there with you, that I'd really like to go do this thing, but I can't do it because I'm scared. That's the kind of stuff we're talking about. All right, moving on to social phobia, or now we call social anxiety disorder. This is really common. So this is a marked fear, anxiety about situations during which the individual is exposed to possible scrutiny by others. So social anxiety disorder very much characterized by thinking other people are judging you. And so the individual fears that they would act in a way or show anxiety, and then that will be negatively evaluated. So oftentimes social situations are avoided or endured with intense anxiety. This results in functional impairment, and fears are out of proportion to the actual threat. It has to last 6 months or more. 7% of US adults had social anxiety in the past year. That number is probably way higher right now with people coming out of hiding from COVID. And then a little more common for females and males. And then an estimated 12% of US adults will experience social anxiety disorder at some time in their lives. That's been causing impairment for more than 6 months. What do you think the most common type of social phobia is, or what kind of social situation causes people the most, or the largest number of people impairment? What situation would most people say causes them the greatest impairment? I feel like this is like a Family Feud kind of question. You all are all over it. So most of our response is public speaking. Yep, speaking in public's number one. Then other kinds of performance situations, being up in front of people, and then when this is really more kind of universal, just like Darla's pointing out, just being around others, shopping alone, going to the grocery store can feel terrifying when you think everybody is staring at you and judging you. That's what your mind is telling you is going on in that situation, and it's really, really unpleasant. But most common, public speaking. All right, panic disorder. So Panic disorder is characterized by recurrent unexpected panic attacks. So once again, we've got this experience of having a panic attack, and then when that's occurring in a specific way, in a specific pattern for long enough, that's when you meet criteria for panic disorder. So we can define a panic attack as an abrupt surge of fear and discomfort reaching its peak within minutes and including 4 or more of these symptoms. So palpitations, pounding heart, increased heart rate. So my heart is beating. Maybe I start sweating, probably like sweating profusely. Maybe I get trembly or I'm shaking. Oftentimes people's breath will get shorter. So they're like short of breath. They're breathing really rapidly. Sometimes people feel like they're choking or they can't get enough air in. People oftentimes experience chest pain or discomfort. They may feel nauseous or feel like they're going to throw up or have diarrhea. People may feel dizzy or lightheaded. They may feel chilled or feel hot. They could have paresthesias, which are these like tingling sensations in your limbs. People may experience derealization or depersonalization, where they feel like they're outside of themselves looking in, or just feel like outside of, just really characterized by feeling outside of yourself. People oftentimes feel, or they have a fear of losing control, or they think that they're going crazy. They think that they're going to die. And as you can imagine, this is really terrifying. I'm curious, does this sound familiar to anyone? A lot of people have had panic attacks. I believe this is on our next slide. About 20% of people have had a panic attack before. I am one of those lucky 20%ers and have had a couple of these throughout my life. It's again not something I would wish on anyone, very unpleasant. And mine were even pretty mild overall. I'm a psychologist, right? I know what to do if I start having a panic attack, but it doesn't make it more pleasant. It just helps you feel like you're not losing control because you've got a better explanation of what's going on. Yeah, so people are pointing out, coping skills can be super helpful. So you know what to do. You know what's going on when you feel this, so you know what to do to help get out of it. Yeah, then people are pointing out some specifics here. Yeah, so like Jessica says, well, I do this if I would have panic attacks if I was getting dental work done. Or like in response, somebody else says in response to a traumatic situation. And that's important to call out here because you can have panic attacks associated with other kinds of things going on and not meet criteria for panic disorder. Panic disorder is like particularly nasty because it like comes out of the blue and people can't anticipate it. Where a panic attack, you're like, oftentimes there's a pretty predictable situations that people are like, yeah, if I do this, I could have a panic attack, like get dental work done. But panic disorder is like just hits out of nowhere, particularly scary for folks. Okay, a little bit more about panic disorder. So about 5% of the general population would meet criteria for panic disorder. However, 23% of the population has had a panic attack at some point. And then panic disorder without agoraphobia is more common. We'll talk about agoraphobia in just a second. Average age of onset, 20s, early 30s, more common in women than men. Men with panic disorder are more likely to self-medicate. You can probably guess that alcohol or anything that helps reduce anxiety is probably going to be what they're turning to self-medicate. And you see panic disorder frequently comorbid with depression, PTSD, substance abuse, personality disorders. So people with these other conditions will also have panic disorder. So yeah, no fun if you're experiencing these kinds of things. All right, let's talk a little bit about agoraphobia. Actually, I remembered the question that I wanted to ask you all. What can people do if they're having a panic attack to help get through that? kind of grounding skills are you talking about, Jessica? Yeah, so people are saying breathing, call a friend, grounding, breathing, grounding, exercise, deep breathing, counting, positive self-talk, using mindfulness or diaphragm for like paying attention to your breathing, breathing techniques, distraction. Awesome. Yeah, remove extra stimulation if possible. That's a good point. Yeah, really good answers. Basically anything that helps you think about what's going on more objectively. And most of these responses, also involve deep breathing. So we really want to activate our parasympathetic nervous system. We want to do deep breathing and change this pattern of shallow breathing, because the shallow breathing is actually producing a lot of the symptoms. So when our carbon dioxide levels get off in our bloodstream, that can cause people to have more of these physical symptoms. So one of the remedies for this is focusing on deep breathing, getting more oxygen back into our blood, and also balancing the levels of CO2 and oxygen. Yeah, like what Darla's saying, stand up and raise your, so another physical practice, stand up and raise your arms over your head, reaching up to the sky. Yeah, getting along to the lines of like some like yoga, like grounding kinds of poses there. Cool. This is a great, Melanie. Yeah, so the 5-4, oh, you're saying 5-4-3-2-1 is a specific, not just counting, Kyle. Yeah, so you name 5 things that you see around you, 4 things that you can touch. Yeah, so it's like this sensory experience that kind of calls you to be more mindful of what's going on. Yeah, forces you to be more in the present moment. Thank you for clarifying. That was not going to be fair just to say, yeah, just count 5-4-3-2-1. So that could be helpful, not quite the same thing, right? I like it. I like this version of 5-4-3-2-1. I think that's a more effective one than just counting. Okay, moving on to agoraphobia. So agoraphobia used to be classified in combination with panic disorder. Now it gets its own place in the DSM. So frequently occurs with panic disorder, but not always. And it's a lifetime prevalence, a little over 1%. And agoraphobia is characterized by fear or anxiety about avoidance of situations in the social environment. So being afraid of crowds, public transportation, open or enclosed spaces, being outside alone. And the thoughts that people are having are oftentimes kind of characterized by, like, escape would be difficult. Like, I can't get out of here. If I were in that situation, I wouldn't be able to get out, and that would cause me big problems. There will be no one to help me, or I'll experience this extreme embarrassment. Like I could have a panic attack in the grocery store, and that would be terrible. Or like I'm going to throw up all over myself, if I go walk on 8th Street, that would be the worst thing ever. So they get just kind of stuck thinking about these things, that they're going to get stuck, or that they're going to get stuck, or they're going to experience something terrible in those situations. And the better option becomes, well, I should just stay home. And then people really kind of get stuck in their environments. And as you can imagine, that self-reinforces itself, because if you never leave your home, then you can never be in one of these situations where these terrible things occur, and your brain says, better safe than sorry. If you leave, this terrible thing could happen, and it makes it more likely that they stay home again and again. So it's a lot of these, or anxiety in particular, is characterized by negative reinforcement. So we remove these negative stimulus by staying home, and then it makes it more likely that I stay home again, and it gets people really stuck. People are worrying about my timing here. I promise I'll get through it. We got 15 minutes left. You may have to stick around later to hear me talk about cannabis. That's not part of the regular presentation, but I will talk to you all about it if you want. Okay, generalized anxiety disorder. Okay, so this is probably one of the more common anxiety disorders, certainly that I see people get diagnosed with. It affects 3 to 4% of the population. And like when you actually meet diagnostic criteria, this gets diagnosed all the time in the medical system, with I don't think actually meeting criteria for it. People are experiencing anxiety that's distressing, but probably not to the extent of generalized anxiety disorder. Just another one of my pet peeves about diagnosis. Okay, so it's often comorbid with other medical complaints, because people experience a lot of physical symptoms when they're feeling more anxious. So people oftentimes have more muscle tension, which can also cause other problems, especially with chronic pain. They can have insomnia. They feel more restless. They have difficulty concentrating. They have like unfocused anxiety. Their brains are just running around worrying about things left and right. Oftentimes these are about minor daily life events, like, what am I going to eat for dinner tonight? I don't know. I don't know what I'm going to do. And then people start feeling anxious about their anxiety. They're worried about when they're going to feel anxious again. So now I'm worrying about worrying. It usually starts earlier in life and kind of ramps up throughout life. And it can occur in any age group, but most of the time you're going to see this like expressing itself earlier in life. So the one thing that I wanted to say in terms of getting diagnosed with generalized anxiety disorder is all these different disorders that we've talked about have to be causing some sort of impairment in people's day-to-day life. And sometimes I see people getting diagnosed and treated for this when they probably wouldn't meet full diagnostic criteria. Maybe the treatments that they're using are helpful. Sometimes I think that's debatable. Okay, obsessive compulsive disorder. So presence of obsessions or compulsions or both. So obsessions include intrusive thoughts, urges, impulses. And it's really important to point out here, people don't want to be thinking about these things. They really rather not be thinking about these things, but they can't help themselves from thinking about them. So these thoughts are intrusive, unwanted, and they cause them more anxiety or distress. What do you think happens when you try not to think about something? How well does that work? So in OCD, of having obsessions, I'm trying not to think about things. I'm trying to ignore them. I'm trying to suppress them. I'm trying to neutralize them. I would say the vast majority of time, trying not to think about something results in people thinking about it more. It takes a lot of cognitive energy to not think about things. And this is kind of how OCD becomes really like consuming, because people are working so hard not to think about things, or in just a second, they're engaging in compulsions to try to make that go away, that it really just makes the obsessions and anxiety increase over time. So compulsions would mean behaviors or rituals designed to decrease anxiety created by obsessive thoughts. And the types of compulsions that are really common, checking things, ordering things, arranging things, washing things, counting things. There's a lot of different compulsions that people will engage in. And then once again, for this to be a disorder, this has to be like taking up a lot of people's time and interfere with their functioning and causing them distress during the daytime, or I guess the nighttime. Importantly, we'll talk about how some of the nuances here. So lifetime prevalence about 3% or 2.5%, a little more common in women than men. However, 10 to 15% of the population will engage in compulsive checking behavior of some sort. I know me personally, I will check locks sometimes. And I think there's a really good chance that I already checked the lock, but I'll go check it again. And so like in my case, that takes about 30 seconds and it occupies a really small part of my life. Do you think that I would have obsessive compulsive disorder because I check the locks in my house more than I need to? Thank you, Diane. I wouldn't meet criteria for obsessive compulsive disorder, but I do have a little obsession and compulsion that I'm engaging in. So I'd probably be in this like 10 to 15% of the population, just a little neurotic about that. Okay, oftentimes onset is in adolescence to young adulthood. I think especially like in young, I think for guys like myself, it occurs, like teenage years, pretty common. One of the other things that you'll kind of see like with obsessive compulsive disorder is that people are oftentimes experiencing feeling like they're out of control in other areas of their lives. They don't have control there. And so the control starts manifesting in things that they can control in their lives. So course of OCD is chronic. You do see this across different cultures. Oftentimes comorbid with depression, you can imagine. If you're stuck in your home or something because you have OCD, you're probably going to start feeling depressed. You may also have other anxiety disorders. And that other one was like body dysmorphic disorder. So you see yourself differently than how you actually are. Okay, PTSD. Lifetime prevalence is about 7%, affects 10% of women or 4% of men. And so some of the important notes here, PTSD is characterized once again by intrusive thoughts, avoiding situations or thinking about things that remind you of the thing that happened or the traumatic event you experienced, having negative thoughts about yourself, the world, the future, other people. And oftentimes depression or irritability are going to go along with that too. People are oftentimes experiencing more arousal. They're like on edge and increased reactivity because they're literally like on edge. So there are a lot of criteria for PTSD. We'll go through these quickly and then move on to substance use pretty quickly. So anyways, criterion A, you have to experience a stressor. You have to experience some sort of traumatic event. So direct exposure, either witnessing in person or indirectly, or repeated or extreme indirect exposure. You have to have intrusive symptoms, so intrusive memories, traumatic nightmares, dissociative reactions, marked physiologic reactivity after exposure to trauma. Criterion C, avoidance. So you're avoiding thinking or feelings that go along with those thoughts that you're having about it. Maybe you can't remember key or things that happened during the traumatic event. You've got negative beliefs about yourself, the world, blaming yourself or other people for causing the traumatic event. Alterations in arousal and reactivity. So maybe you have an irritable or aggressive behavior, you're hypervigilant, you're always looking out for something to happen, you've got difficulty concentrating. This has been going on for more than 1 month, and it's causing significant distress or impairment, and it's not due to medication, substance use, or illness, just like all of our others. And you have to be experiencing this for at least 6 months after the trauma. So if you experience it in the 6 months before the trauma, we wouldn't call it PTSD until 6 months had passed, because this would be really common immediately after a traumatic experience for some people, or a lot of people, that will decline over time. We give them 6 months. Once again, just another one of these arbitrary things. What's the difference between 6 months or 7 months or 6 months and 5 months? But we pick a number and we go with it. Okay, where am I time? I've got about 10 more slides. We'll go through substance use pretty quickly. There's a big reclassification of substance use disorders, and really now we view all the symptoms of substance use disorders the same. You could just be using different substances and then meet criteria for a substance use disorder. So most important part here, probably the symptoms of substance use disorders. Okay, so our symptoms are consuming more of a substance than originally planned, worrying about stopping or consistently failed efforts to control one's use, spending a large amount of time using drugs or alcohol or doing whatever is needed to obtain them, using the substance is resulting in a failure to fulfill major role obligations. So once again, that significant impairment. People experience craving for the substance. They continue the use of a substance despite health or mental health problems caused or worsened by it. They continue to use it despite it having or causing problems with relationships in their lives. Maybe they're using substances in dangerous situations, or their substance use is causing them to be in dangerous situations. They're giving up activities in their lives because of drug or alcohol use. They're building up tolerance. And if they stop using it, they're experiencing withdrawal symptoms. So these are all the different criteria for substance use disorders. Okay, so then we've got different levels of substance use. So if you had 2 or 3 of those symptoms, then you would meet criteria for a mild substance use disorder. If you had 4 or 5, it would be moderate. Severe would be 6 or more. Once again, just arbitrary. We've got numbers, but it gives us a better understanding of where people are at on these spectrums. So other specific substance-induced disorders would be things like substance-induced intoxication, substance-induced withdrawal, and then central nervous system symptoms that develop in the context of substance use, like you have psychosis because you did acid. That would be substance-induced psychotic disorder, substance-induced anxiety disorder, substance-induced depression. You're experiencing these symptoms of mental health conditions because you used a substance. The types of substances included in DSM-5 include alcohol, caffeine, cannabis, PCP, hallucinogens, opioids, inhalants, sedatives, hypnotics, anxiolytics, stimulants, tobaccos. I just made that up. Okay, then all those things can fit into these other categories of substances that are depressants or central nervous system depressants, central nervous system stimulants, opioids, hallucinogens, and then so the things that you all mentioned, ketamine, cannabis would fall into the hallucinogen realm, and then our other inhalants, steroids, nitrous oxide, other things that can get you high. Since I'm right at 4 o'clock, I think I'm going to skip over these prevalence slides. Probably not as important. I'd rather answer people's questions about symptoms since we are so close to being done. I did have a slide here specifically about alcohol-related disorders, and it's really just applying what we were talking about before to alcohol specifically. Few little nuances of alcohol withdrawal and delirium. Alcohol withdrawal includes things like tremors, nausea, anxiety, hallucinations, agitation, insomnia, delirium, and then more extreme from that would be alcohol withdrawal delirium, or what we used to call delirium tremens, and experiencing things like disorientation, hallucinations, fear, you're really suggestible, tremors, you're sweating a lot, your heart rate's variable, you have fevers. So yeah, once again, really no fun for people to be going through these kinds of things. All right, well, that was a crash course in psychopathology. When you're talking about a field that is really everything related to mental health, it's pretty broad, but hopefully you found the presentation today interesting and maybe give you a better way of thinking about some of these things, though I know you all are pretty well adept at this stuff, and yeah, you're doing it day in, day out, so you're familiar with it already. So in summary, we can think about psychopathology as being characterized by deviance from cultural norms, causing people distress, causing them impairment in their functioning, and could be also including danger in terms of harming other people or themselves. We talked about DSM-5. That's our best guess at a classification system for mental health disorders. We talked about common mental health disorders, including the mood disorders, anxiety disorders, briefly touched on the substance use disorders. And my final little note here is, I really think that the better we can recognize and understand mental health disorders, the better we can help manage or recover from them. And I think that's why, these kinds of presentations can be helpful, because if people have a better understanding of what they're experiencing and why they may be experiencing what they're experiencing, then that gives them that allows them to seek help and allow other people to understand what they're going through. So, all right, we're right at 4 o'clock. I am happy to answer any questions if you want to stick around. but also understand, that many of you probably have other things that you want to be doing this afternoon, or have to be doing this afternoon. So my feelings will not be hurt if you leave. And then Anna, is there anything else that you wanted to say to the group before I start taking some questions?
Yeah, for sure. I'm more than happy to keep this webinar going for maybe like 10 minutes or so if people have the time and want to stick around. Yeah, I just want to thank everyone for being here, and I want to thank Dr. Davis for just always being such a joy to work with, and his presentations are always awesome. I'm gonna go ahead and just put Empower Idaho newsletter sign up for different events like this that we hold. Keep a lookout for Dr. Davis's next Empower Idaho presentation, which I'm sure will be sometime this year. We'll have him back. But also, there's an evaluation, again, really helpful for you to fill that out. That'll pop up after the given session. So that's kind of all I've got if you just want to take the questions now, Kyle.
All right, thanks. So I'm just going through some of the comments here. I like what Jess is talking about. The kinds of things that you see or just people use in everyday language. People say, oh, you're OCD or you're bipolar or you're schizo. And it really, personally, it really irks me to hear, those kinds of conditions or terms used in that way. It's not fair to people that have been diagnosed with them, nor are they usually all that accurate for what people are actually trying to describe. Yeah, totally agree with that, Jessica. All right, so did anyone have a specific question about ketamine, marijuana? What were the questions about those things? This is funny. Yeah, so you all are welcome. And now people are, what are my opinions on microdosing LSD? So we'll stick to the science here. But I think in general, when you're talking about some of the psychedelics in controlled settings, there's some really interesting evidence that using these substances in this way can be really helpful for some mental health conditions. In particular, medicated or substances like ketamine, psilocybin, LSD, have been demonstrated to be effective treatments for things like depression, post-traumatic stress disorder. Really interesting, to think about some of the reasons why those kinds of experiences can help treat mental health conditions. My general take on it is that anything that can shake up how you view the world and allow you to feel differently, think differently, even for a short period of time, can open you up to thinking about things in different ways in the future. And I think that that's what you see when you look at the studies that have been done in this area, and you interview people that have been in these studies, and they feel that change in how they're feeling allows them to recognize that things could be different than how they are feeling most of the time. And then that kind of faith that things can be different oftentimes allows people to change the way that they're behaving. They thinking about things differently. They feel more connected to other people. And so it's a fascinating area. There's a lot of this work was done like in the 50s and 60s, and then got really shut down, and is just now kind of seeing a new life. So I think we'll be hearing more about these kinds of treatments in the future. Yeah, people like using edibles once in a while to relax. In terms of, I don't think there are like right or wrong answers to these kinds of things. If we think about it in the context of mental health conditions, some people, that's probably something that they can do and it's not going to cause them more problems. Other people, it can exacerbate their problems, depending on how they're using them. Specifically, if people are using substances to avoid things, then just like counting all the number of ceiling tiles or the number of steps or something alleviates your anxiety temporarily. Doing that makes it more likely that you're going to count things again or worry about that. Same thing goes with using a substance like this to avoid. It's going to make it more likely that you do that again in the future, and then that could cause more problems. Is ketamine effective for depression in the long run? Kristen, I'm not gonna just make up something. I don't know long-term efficacy data of using ketamine for depression. Moto says, is there a variety of diagnosing mental illnesses? I think in like Western culture, there would probably be, the DSM, and if you look at other cultures that use DSM, in most of our European countries, really across the world, you probably, everybody's trying to use the same kind of approaches there. But I'm sure their individual cultures have their own ideas about how diagnosing things, and I'm not going to say whether that's right or wrong. Tracy said, why is marijuana considered a hallucinogen? So I think in terms of substances, it changes the way that you're thinking about things, which, it's kind of like most substances they change the way you're feeling to a certain extent. But I think it's more along the lines of, hallucinogens, like seeing things or hearing things that aren't there, but also just thinking about them differently. Yeah, that's a good question. This presentation had been developed to talk about psychedelics. I would have a better answer for you. But yeah, you all are giving me some wild cards here, which is fun. But I don't have the best answers because I wasn't as prepared to answer them. Okay, yeah, just asking about TMS, transcranial magnetic stimulation. I've heard from folks that say it's helpful, and I've heard from folks that say it wasn't helpful. Yeah, I think for some specific conditions, there is evidence that it can be helpful, but it's probably not one of these things that's going to be a cure-all for everything, because I don't know, one of the things I think a lot about with mental health is, like, why are people what are their life experience? How does that influence the way that they interact with their world or think about their world? And something like TMS, could change the way your brain is functioning for a while. But if you're not changing the systems that you're in or the way you're interacting with people, you're not changing those kinds of things, you're probably likely to fall back into some of the same patterns again. So just like we were talking about with psychedelics, seeing that things could be different even for a short time can allow people to start doing things differently, thinking differently about things. You can tell I'm a cognitive behavioral therapist. I talk a lot about behaviors and thought patterns and changing those to help people feel better, because the same thing goes with even like antidepressants. I think a lot of that has to do with getting people to a point where they can start doing things that help them feel better again. So yeah, try not to put all your eggs in one basket, with something like that. But if people are motivated and they're also willing to start doing other things in their life that could help them feel better, then a treatment like TMS could be really helpful. And probably for some people that are not changing anything else too, sometimes. All right. Any other wild card questions here?
I enjoyed your answers. That was fun to listen to. For sure. Yeah, well, I always love your sessions just because there's so much engagement from folks. And just, I guess if there's some more questions coming in, I just want to thank you all again for sticking around and for coming and learning with Empower Idaho again. And, keep a lookout for future events we have coming up. I guess the next thing I want to say is if you're pursuing continuing education credits for any of these sessions in this conference, please look for an email from us no later than May 7th with your CEU certificate, okay? So, and if you have any issues with that, please do not hesitate to email us to ask questions. We will provide the answers that we think will help you the best and most. So, anyway, Dr. Davis, have a great weekend. Thank you again for your time. Everybody, I hope you enjoyed this nice weather we're having down here in Boise at least, and I hope to see you at our next event. Thanks, everyone.
Yep, thanks. Bye.
Bye.